Hi there. Welcome to this Stop TB Canada webinar. I'm Dr. Elizabeth Ray. I work with the TB program in Toronto and also with Stop TB Canada. And we are very happy to have Dr. Dick Menzies talking today about a large study of using 4 months rifampin for treatment of LTBI that was published last summer. Dr. Menzies has a long history of involvement in tuberculosis care and research, beginning in Lesotho and since then in Montreal, where he developed a tuberculosis research program of clinical and epidemiologic studies linked with a large multidisciplinary clinical service at the Montreal Chest Institute and the Public Health Unit of Montreal. He is widely published. He's been a consultant to national TB programs and with the WHO. He was the editor of the most recent Canadian TB standards, and we are very, very happy to have him talking today. So everybody is on mute. So if you have questions, we're going to hopefully have time for questions at the end of the talk. So please type your questions into the question box that you should see on the right-hand side of your screen. And we'll go through some of those questions at the end of the talk. So Dr. Menzies, over to you.
Okay, good. Thank you. Thank you very much, Elizabeth. So thanks to the organizers, Stop TB Canada, for inviting me to give this talk. I'm delighted to talk about this, one of my favorite topics. I'm certainly hoping that everyone can hear me, but I guess if they can't, since you're all muted, you have to type in that you can't hear me. I'll try to go through the slides in about 45 minutes and leave time for some questions at the end. Okay, so here I go. So conflict of interest first. I have no really commercial conflicts of interest. I do get grants from CIHR with a bit of luck, and I've had some grants from World Health Organization also for multi-drug resistant TB and analyses related. So outline, I'm going to talk a little bit about the rationale for therapy of latent TB and some of the sort of risk-benefit general considerations. And then I'm going to focus on a whole series of randomized trials that have been done comparing mostly 9-INH, some 6-INH, to shorter regimens. And I'm really going to focus on 3 regimens, so-called 3 to 4 HR, which is 3 to 4 months of INH and rifampin, 3 HP, which is 3 months of INH and rifapentine. This is once weekly, 12 doses. And 4R, which is kind of a local favorite, and the results of the study that I published last summer. Okay, so first of all, just again, I'm sure everybody who's listening knows this, but just to make sure we're all talking about the same thing. So what is latent TB? So it's persons with dormant or latent TB who may develop TB in the future. There's no signs or symptoms. They're not contagious. That's a common clinical question, or at least from patients. And really the only manifestation is an immune reaction to MTB antigens. So a positive tuberculin test, a positive IGRA, that's often the only thing. Note that most people with latent TB have normal x-rays. Even granulomas are not common. It's obviously helpful when you see it, then you're more kind of confident. But most people have a normal x-ray and still can develop active TB later. Okay, so what are the considerations? So there's kind of individual benefit and public health benefit. So public health benefit, you know, of course, if you prevent TB, you prevent transmission of future cases. But honestly, the primary consideration is always individual benefit. If you have an individual where you think the benefit is not outweighed by the risk, I don't think you should be treating them, even if there is some potential public health benefit. Maybe that's a point of discussion, but I think most people would agree with that. So again, the primary consideration is that balance of risks of therapy versus benefit, which is really, what are the risks, which is really driven by the risk of developing active TB in the future. So schematically, I kind of think of it as a bit of a balance. Again, most of us do this very intuitively faced with a patient. So risks of therapy are generally increased with older age, with liver disease, cirrhosis, hepatitis C, or with regular alcohol use. So regular meaning daily. Don't ask me for a definition beyond that because it's difficult to give. What are the benefits of therapy? So the benefits of therapy are greater as the risk of disease increases. So clearly therapy is more important when you have high risk of disease. So HIV infected persons, diabetes, abnormal X-ray, fibronodular disease, close contacts, recent contact. These are all people with increased risk of disease, so increased benefits of therapy. So when we think about active disease and preventing it, we first need to think, well, what's the risk? So a young, healthy adult, so your typical, let's say, nursing or medical student that's found to have a positive tuberculin test and presents, let's say, setting aside false positives, whatever, let's say they really have the infection, still their risk of disease is relatively low, 5 to 10% over their lifetime. Estimates vary. But if you have risk factors, so HIV infected, the cumulative risk would be over 50%. Even diabetics, they may have only a 2 to 3 times relative risk, but again, they have diabetes often from young adult life or from middle age, so the risk mounts up over time. Very young children, I think most people are aware, have very high risk of disease, highest in the first year of life. So an infant exposed and infected, 50% will develop disease, usually TB meningitis or miliary disease, and rapidly within months. So that's why we prioritize young kids for contact investigation. So, okay, so that's risk, but what about the consequences? Because certainly I've had both physicians and nurses ask me, but also patients frequently, well, okay, why don't I just wait till I get active disease and treat that? And that's true, it's treatable. It's probably worth pointing out that still in Canada, there is some mortality, although mostly it's in the elderly, but that 4 to 7% comes from Canada over different years. So it's either elderly or delayed diagnosis. Occasionally it's hemoptysis or other complications. So there is some mortality, but there's also disability, and that's what's really, I think, been forgotten. A US study that 20% loss of lung function, low and middle income countries, similar but more, averages about 25% loss of lung function. So equivalent to having a lobectomy is having active TB, and if you're a young adult, that's an important potential disability. I would note that in the risk-benefit analyses that have been done in the past, the disability has not been considered. Okay, so again, some of you may be familiar with this. We've developed a website. So if you have someone with a positive test, either a TST or quantiferon, you can go to this website. And if you just type in TST in 3D, it'll usually come up. English or French, you enter what you see on the screen, particularly risk factors, and then you hit submit, and it'll give you a likelihood that the test is true positive. Again, for quantiferon, it's not much of a doubt, but for TST, it's more important. And then it'll give you a risk of disease estimated, and it'll give you an estimated risk of hepatotoxicity. Again, that's based on INH. We are in the process, albeit a rather slow process, to develop and update this for RIF as well. Okay, so again, the last sort of point, you know, I often find it puzzling when I give talks or I talk to docs or nurses, and they're like, oh, you know, we don't need to treat latent TB. It's not that important. Why would we treat? We can wait. And, you know, I ask when I give talks, who in the room would treat hypertension? Everybody puts up their hand. There's no doubt about that. But then we come to latent TB and you see it's kind of similar. It's an asymptomatic condition. It has potential very serious complications of death and major disability like hypertension. The difference is that latent TB, the maximum treatment is 9 months. Now, as you'll see as we go along, 4 months. Yes, the treatment can have side effects. It does require close monitoring. Medications are cheap, whereas hypertension is quite different, as you know. So there's no debate about treating hypertension. I think there should be no debate about treating latent TB. maybe about who in specific instances, no question, there's room for judgment, but in general, I don't think there should be much debate. Okay, so now the options. So again, I'm only going to focus on these four. I'm going to review quickly 6 to 9 months of INH, the current standard. And again, 6 months is the WHO standard and is basically the trade-off between completion and the ideal. So the best study that was probably ever done for INH was Eastern European trial, the Union trial, published in 1982. And as you see, the people who took INH for 12 months and took it actually completed it every month as well. 93% reduction in incidence of TB over 5 years compared to the placebo group. This was a study with 7,000 people per group, so a large study. These estimates are pretty robust. You see that 6 months is clearly not as good, but what's interesting is that when you did an intention to treat analysis, because so many people didn't finish 12 months of INH, the actual effectiveness of INH is much less at 12 months and is very similar to 6 months. And because of that, WHO in its wisdom has recommended 6 months of INH, not longer. But I think, again, in settings where we have resources, longer is better. Now, how much longer is the next question. So George Comstock did a reanalysis of numerous studies done among the Alaska Inuit and looked at various durations of treatment from as little as 4 months to as long as 21 months. Those are the dots. And by his calculations, there was kind of a sweet spot around 8-9 months where you got seemingly pretty good efficacy and yet, kind of for the least amount of time. 6 months was clearly not as good. 5-6 months, not as good. So based on this graph, really this analysis alone is how we came up with 9 months INH for in the US and in Canada. So 9 months seems to be about as good as longer, and that it's kind of been assumed or understood to be about 90% efficacy if you take it. But the downside, as again, I think everyone's aware, is the risk of hepatitis. So again, in young people, less than 20, it's rare, but as you get older, there's a steady and progressive rise, which is a bit, I'm not sure what the right word is, but anyway, not linear rise, so that over 65, you're seeing more than 5% with clinical hepatitis. And a study done in Quebec, I'm just going to quickly flip to the next. No. So a study done in Quebec using health administrative data, we found that 2% of persons aged over 65 who received INH and did not have a diagnosis of a liver disease in the preceding 3 years were hospitalized for a liver problem within 6 months of starting INH. So again, that's a pretty heavy proportion. We've also subsequently done another study with a PhD student here, and actually liver transplants average about 1 a year in Quebec with very similar sort of no history of liver disease before, get INH, and get a liver transplant within the next year. Again, from administrative databases, we can't be always certain of cause and effect, but it's pretty clear that INH has a continuing toll, if you will, at least on the livers. And a compilation of studies. So we have the original study back in 71, 72 by the US Public Health Service, where they identified age 35 as a cut point. Then the Eastern European trial, actually the mortality, this was the same trial I showed you at the beginning. There was 14 per 100,000 mortality, so there were some deaths in that trial. CDC surveillance study shows mortality falling, and again, the most recent estimates from Shelley Salpeter, a study she did up till 1990, really mortality is low, but not zero, so still deaths occur. Okay, so overall, so what's good about INH is that it works. If you take it for 9 months, it's very effective. And there are many trials that have consistently demonstrated benefit in many populations. On the other hand, we know that it's not well completed and accepted. The drug-induced hepatitis is important, and deaths still occur, at least liver deaths and liver transplants. And the costs, although the INH is very cheap, you need to follow people closely because of these side effects, and the follow-up is expensive. Okay, so that, all the problems with INH engendered interest in shorter regimens, all of which contain a rifamycin. So first is 3 to 4 months of INH and RIF. Which is used quite widely, a few centers in Canada and certainly in the UK and other places. So this systematic review was published in 2005, largely HIV infected, although one was Hong Kong in silicotics, comparing INH RIF and INH alone. And you see that the efficacy, so in terms of incidence of TB, was very similar. So the INH was mostly 6 months, and the INH and RIF was 3 or 4 months. It depended on the study. I haven't actually marked that here. However, the downside of all this, the serious adverse events, the rate was pretty much identical as well. So it didn't seem like 3 or 4 months of INH RIF was any better in terms of patient safety. So my take on all this evidence, first of all, 3 to 4 months, we don't give people 3 or 4 months. We don't usually even let them choose. We usually suggest you should take 3 months or 4. And honestly, is it 3 or is it 4? I would suggest it probably should be 4, since 3 months is generally not enough. The comparator in many of these studies was 6 months INH, and that's not optimal, as the efficacy of 6 months is 70%. And most importantly, the toxicity was not better. We need a regimen that's safer than INH alone. And I think that that's what the INH is doing in this INH RIF combination. The INH is giving you the toxicity. The rifampin is giving you all the effect. So my conclusion is forget 3 or 4 INH RIF. Forget it. Stop it. Don't use it. Switch. Really, it's toxicity for nothing. Of course, that's my opinion only. Okay, INH rifapentine. So INH rifapentine is a drug that can be very much like rifampin in terms of activity on tuberculosis, but it has a half-life that is 5 times longer. So you can give it only once a week. So that's obviously very handy. And you can give it by DOT, so DOPT once a week. And in mouse studies, 3 months of a combination of INH rifapentine seemed to be as good as 6 months INH or even longer. So a large-scale trial was mounted, it was randomized, it was done in the US, in Canada. There were some centers in Canada that participated, Montreal, Winnipeg, I believe Vancouver. Also Spain and Brazil. It was adults and children, persons living with HIV. They actually produced 3 separate sort of they did the adults, but the children and persons living with HIV were like sub-studies within the main study, and I'll show those results separately. And they looked at active TB, adverse events, and of course, completion. And just a reminder, so 3HP is once a week, 12 doses in total. And the comparator is 9 months daily INH, so 270 doses self-administered. Okay, so in this trial, which was a big trial, as you see, large numbers randomized, over 3,500 to INH, almost 4,000 to 3HP. Completion rates, not surprisingly, were significantly different in favor of 3HP. And TB disease, clearly 3HP was as good, really better than, although not significantly, better than 9-INH, especially in the group that took every dose. So 9-INH, we know it's about 90%, or we think. So you see very low rates of disease, but in the 3HP, even lower. So it seems to have excellent efficacy. So what about in kids? So again, a smaller study, a total of about 1,000. median age 10, none under 2 because of some concerns about rifapentine in under 2. Completion was better, although it was actually quite good in both arms. Grade 3 to 4, there was actually a little higher with 3HP. So grade 3 to 4 adverse events are adverse events that are considered serious enough that you should stop the drugs. And, you know, it's kind of difficult to summarize them in one word, but they're serious enough to warrant, you know, follow-up, close follow-up, sometimes hospitalization, sometimes not, but they're deemed to be something that, you know, poses at least a risk of serious health problems. Grade 1 and 2, on the other hand, are mild, you know, small rash, aches and pains, bit of nausea, those kinds of things. So those were also a little higher in the 3HP arm. None of that significant. And there were 0 TB cases in the 3HP arm and 3 in the INH. So if anything, 3HP was better. Certainly it was judged non-inferior in terms of efficacy for TB. And then again, another group of HIV infected, relatively small numbers, about 400 in total. Completion again, very different, favoring 3HP. The side effects now were quite similar, and a number of TB cases actually again favoring 3HP, lower rates in the 3HP group than in the 9-INH. So across the board, children, HIV infected, non-HIV infected adults, better completion, and very good efficacy for TB prevention. However, in the adults, non-HIV infected, there was sort of a caution, and that is displayed here. So drugs stopped for adverse events. So again, this is provider stopped the drugs, judging that there was something that they didn't want to continue. So that's a, you know, a kind of a clinical threshold. So you see that actually 3HP was more common than 9-INH. And hepatotoxicity, as expected, was much less with 3HP. They were only getting INH once a week for 12 weeks. But there was this hypersensitivity that occurred. So you may ask, what is that? Why did they stop for hypersensitivity? So I'll show you a case report, which I personally observed because this was a patient that we randomized, or enrolled and randomized at the Montreal Chest here at McGill. And so I got to personally observe it. And then I'll show you their subsequent publication with more details about this. So first, the case report. A cautionary note to all those who would like to use 3HP. So 50-year-old Canadian, really healthy, no other medical problems, close contact at work, TST positive, randomized to 3HP. All was fine for 6 weeks. And week 7, he received the dose. By protocol, the research assistant stayed with him for about 20 minutes, made sure he was okay. He was okay. She left and came back to the hospital. 2 to 3 hours later, he called us up saying he really didn't feel well. He was vomiting, abdominal pain, he was dizzy. So, okay, so come on down. So he comes to the hospital in about half an hour. When he arrives, his blood pressure is 60 palpable. He's tachycardic, and really he looks terrible. It looks like he's dying. He was admitted to our ICU, given steroids, 6 liters of fluid, and recovered very quickly, and 24 hours later was discharged, went home. And despite CDC's enthusiasm to confirm that this was really due to the 3HP, he declined rechallenge. Okay, so that's perhaps, again, you know, if you get to see that, naturally it makes you a little leery of using the drug. So their publication on this revealed this systemic drug reaction. So this was kind of what I was describing. So any systemic drug reaction was described, actually that's not 0.3%, but 3.0%. Compared to 9-INH, there were 15 that had something like that. Severe, so again, necessitating urgent treatment and so on. Clearly all in the 3-HP arm, and 4 of those were hospitalized. This includes the one that I just showed you. So these are uncommon, even rare, but do result in hospitalization. And so I think, again, to my mind, it's a cautionary note for this regimen. It's the only downside. Great regimen otherwise, very effective, well accepted, 12 doses, but uncommonly or rarely this thing occurs. So I think you have to be giving it in a setting where you have access to, reasonably, at least access to medical care, meaning physicians, and probably to hospitalization services and resuscitation type services, particularly because this reaction is not well understood and therefore is difficult to predict. We don't really know who's going to get it. And again, in this instance that I just showed you, it kind of came out of the blue without warning. 1 week he's fine, next week he's got this. Okay, so now that sets the stage for 4 months rifampin. Just checking the time. So first of all, this is my only mouse or slide about mouse data. So this is an experimental model of mice that sort of live with TB. And the top row, or sorry, the top line with the solid black dots are mice, the bacillary load of TB in the lungs of mice without treatment. So they sort of live with a fairly heavy bacillary load in the lungs. And then you see what happens if you give them INH or other rifampin or other combinations. So the INH is the graph that falls down slowly and reaches 0 at 6 months. So indeed, very much like clinical experience, 6 months of INH, you see things go down to 0 slowly, and by 6 months you're near elimination. Not quite elimination. On the other hand, the rifampin containing regimens, they're all bunched together. Rifampin alone, rifampin pyrazinamide, and then 3 drugs. And I think you would see that they're completely indistinguishable. And so that really brings the rationale that you don't need 2 drugs, you don't need 3 drugs, you only need rifampin alone, and it seems to act much more quickly than INH, again, in a mouse model. Okay, so in humans with silicosis in Hong Kong, they had a large cohort of mostly men with silicosis, and they had positive TST and randomized them. And you see the group without any treatment, what looks like P1 is placebo. 27% developed active TB over 5-year follow-up. So that tells you something about silicosis and a positive TST. It's clearly an important risk factor. But then the groups that were treated with INH and RIF, 16% got disease, INH alone 14%, and RIF alone for 3 months, 10%. So in fact, RIF alone was the best, although the 3 were not significantly different from each other, and they were all 3 significantly different from placebo. So again, that suggests that rifampin alone certainly looks as good as a combination as it did in the mice. So it supports the theory at least. Okay, so in 2000, RIF alone, 4 months of RIF alone was recommended by ATS and CTS. I'll show you the randomized trial shortly, but there were also observational studies published. Here's one from Maryland, non-randomized, so physicians are selecting patients, maybe patients are also selecting to get 4 RIF or 9 INH. You see completion is much better with 4 RIF, and the hepatitis, so grade 3 to 4 hepatitis, much lower with 4 RIF. So a little bit of history here, personal history perhaps. So phase 1, so a series of randomized trials were done. Phase 1, which was just really to make sure that completion was better with 4 RIF. In other words, it was well accepted, tolerated, people did finish it. That I first applied for funding back in 2001. and finally finished the study in 2003. Took a while to get funding, always does. Phase 2, adverse events and costs. So once we had shown that it was better completed, then we went on to say, well, is it safer for RIF? Because it had to be safer, otherwise there's no point, doing more studies. You really need something that is safer than a 9 INH. So we enrolled 847, completed that in 2007. So it was indeed safer. I'll show you the data shortly. So that encouraged us to go on and apply to CIHR for phase 3 efficacy. And indeed, first we also actually started and finished a pediatric arm and finished that in June 2016. The last person finished follow-up, last child. And then the adult arm, we enrolled a little over 6,000 and completed that last follow-up, finished in April 2017. It was published in summer of 2018. So I'll show you those results. Okay, so going back to phase 1, I'm hoping that everyone can see the full screen here, because for me it's blocked a little bit with these power controls, but if anybody can't see the full screen, please type it in. So for 9 INH, so in phase 1, a very small study, there was obviously a very big and significant difference in completion between the 9 INH group and the 4 RIF. Again, not surprising, but in fact we did the study because in the 1990s, a series of studies were done comparing 2 months of rifampin pyrazinamide with 6 INH, 9 INH, even 12 INH. And in those studies, what was surprising was that the completion was not better with 2 months of RIF PZA. And I think that was because it's a difficult regimen. It's not well tolerated, and it should have been kind of a warning, or maybe it was a warning that was ignored. And so in 2000, when it was recommended and used more widely, then we saw all this hepatitis and it was withdrawn. But it had never actually had better completion, despite being so much shorter. So I wanted to make sure that 4 RIF was completed better. It was. Okay, not much news. In phase 2, a bigger study, again, completion was better. But again, the primary objective of phase 2 was safety. So here you have grade 3 to 4 adverse events. So I'll come to the methods later, but these adverse events were all judged by an independent blinded panel in terms of drug-related and also the severity. And so you see a big difference in 9 INH versus 4 RIF. 4 RIF, a significantly lower rate of serious adverse events, particularly, in fact, really all of the difference is accounted for the difference in hepatotoxicity. So 4 RIF, 7 per 1,000, 0.7% developed grade 3 to 4 hepatotoxicity, significantly less than the group on INH. So this was encouraging as well. So now we had a regimen that's completed better and safer. On to phase 3. So I'm going to show you a few methods. Again, the papers are published. I'll show you where they are. So by all means, or people are welcome to email me with questions. But again, in the interest of time, I'm just going to show a very brief summary of the methods. So first of all, this was a multi-center study in 9 countries. Canada, of course, not in the north, despite the coloring, mostly right along the border with the US, where all the Canadian cities are. Brazil, 3 countries in West Africa, Saudi Arabia, Indonesia, Australia, and Korea. The design, so this was an open label, positive controlled randomized trial. The comparator or the control was INH daily, self-administered, 9 months. The intervention tested was RIF daily, self-administered, 4 months, 120 doses. For the pediatric arm, we calculated doses based on weight and age, following WHO recommendations for dosing. And I've already said about the study, the centers. So blinding is important because it's an open label trial, and especially for clinical TB, you could imagine a provider might have a bias in saying, oh, they got RIF and it doesn't work, and so they have TB now, or vice versa. And the same for adverse events. There could be some bias in what people think. So every possible case of active TB was reviewed by a 3-member panel, all via the internet. They did it independently to each other, blinded to the study drug, blinded also to the diagnosis of the providers, and they judged if it was confirmed, clinical, or unlikely. Same for adverse events. 3-member panel, different people, reviewed independently, blinded to study drug. They judged whether it was likely related to the drug or not, and then they graded it based on published criteria. So ATS criteria for hepatotoxicity, and actually cancer criteria for most of the other adverse events. So the study populations, again, these were people who are TST positive or IGRA positive, although that was a relatively small number. And they had an additional indication. So it wasn't just a young, healthy person with a positive test. It was people with HIV, close contacts, those kinds of things. We excluded people where the index case was known to be resistant to INH or other fairly self-explanatory exclusion criteria. Okay, so on to results. As I said, there's a lot more detail about the methods in the publications. So these were published last summer in the New England. This is the study in children. So again, for children, our objective was really to look at safety and tolerability. Efficacy was a secondary objective. We felt that if we proved efficacy in adults, most people would accept that it works in children too. On the other hand, safety and tolerability in children should not be assumed. So really our scientific advisory committee strongly recommended we study it in children as well, which was done. Okay, so screened a large number, excluded a large number, randomized almost 850. A few were excluded per protocol post-randomization, either drug-resistant index case or like a small child that was and a contact that was TST negative and remained negative after 3 months after the window period. So they were excluded. So first of all, completion of treatment. Again, just as with all other studies, there was a significant difference in treatment completion. For 4-RIF and 9-INH, the treatment completion was good, as you see, meaning, of course, that parents are much more, exigeant, as we say here, than to get their children to take meds than, as you'll see in the adult study, they were for themselves. But a significant difference. Serious adverse events and tolerability. So there were no serious adverse events attributed to treatment. There was one death in the 4-RIF arm, which was a motor vehicle accident and judged by the committee unrelated. And there was one pregnancy, a teenager who became pregnant, but while on INH, again, not attributable to treatment. Minor side effects as well, very similar, as you see. Really no difference in nausea, itching, fatigue, these kind of symptoms that come up. And the provider did not stop the drug, but they just continued. Active TB, so there were 2 cases of active TB, both confirmed, none in 4-RIF, 2 in the INH arm. So actually very similar to the 3HP study. One of the 2 with active TB was INH resistant, but this was a teenager who did not really take any, was randomized to 9-INH, really didn't take it at all, less than 10% of doses, and developed active TB many months later. We didn't have a DST in the index case because this was done in a country where they don't routinely do DST. But the assumption is this was really primary INH resistance. Okay, the adult trial. So again, it was published at the same time, a long list of authors representing the many contributors. So here the primary objective was efficacy to prevent active TB, both confirmed and clinical. And we also looked at completion and safety again. So participation, we screened 17,000. It was quite a big study, as you see, and we ended up enrolling a little over 6,000, of whom I'll show you the completion rates shortly. And we had really quite good follow-up. We did lose some, about 7% were lost to follow-up. So we have some losses. Okay, so in terms of patient characteristics, as you see, the majority, almost 3/4 of all the patients were contacts, and 2/3 overall were close contacts. We had relatively small numbers of HIV-infected individuals, unfortunately, and other immune compromise also fairly small numbers. So completion, again, for RIF, significantly better completion. Overall, the rates of completion are lower in adults than in children, as I mentioned before, but the difference was quite similar, actually. Here it's about 15 or 16%, and the children was about 13% difference. Incidence of active TB. So this is really the heart of the matter. So here we have incidence of confirmed active TB and all active TB, confirmed and probable per person year. You can see the rates are low and identical in the two arms, or if anything, slightly lower in the 4-RIF arm, not significant. These rates were low enough. The difference was small, and even with the confidence intervals you see, we could conclude non-inferiority, which was really we can conclude non-inferiority, which was, sorry, someone said they can't hear me, but anyway, which was the objective of the trial. Again, 9-INH has 90% efficacy. You can't do that much better, but you can at least want to make sure that it's not worse. So here you see that it's not worse than the 90% efficacy of 9-INH. So adverse events, again, as in phase 2, a significant difference with 4-RIF significantly lower. So in this case, we actually had lower overall rates, where 2.3% of people on 9-INH had grade 3 to 5 adverse events. 5 is death, grade 3 to 4 otherwise. Judged possibly or probably related to the study drug, and the drug was stopped permanently. That's the definition of everything seen here. So again, you see a significant difference with 4-RIF, less than 1% having these kind of events, and particularly in hepatotoxicity, very significant difference. Only 11 people, or 3 per 1,000, with hepatotoxicity in RIF. There were some patients with hematologic problems. 5 out of 6 of these were people from West Africa, and their baseline white counts were low, which is described. I'm not quite sure. I don't really know why that occurs, but it seems to be a population, variation. Typical white counts that are normal in normal healthy people can be 2,500. And so in these people, we saw some that dipped below 1,000, and then we had to stop, although they had no symptoms. But nevertheless, for RIF, there is potential for hematologic, a bit more rash, drug interactions, that sort of thing. But overall, still very low rates. So summary of the pediatric study. First of all, there's no serious adverse events attributed to 9-INH or 4-RIF. Very well tolerated in the children and adolescents. Completion rate significantly better. Minor symptoms infrequent and similar. Post follow-up follow-up was very complete. Rate of active TB was low and all in INH arm. In the adult trial, again, a large study. We did have relatively little loss to follow-up in the phase 3, but we had lost some earlier. So overall loss to follow-up worse than the pediatric study. Nevertheless, 4-RIF, significantly better treatment completion, significantly lower rate of grade 3 to 5 adverse events, mainly again due to hepatotoxicity, low rate of active TB in both arms, and non-inferiority. So 4-RIF is not worse. In fact, you would see the numbers, you would say it's the same in terms of prevention of active TB. So conclusion, very quickly. First, I was grateful that no one else had scooped us on this after 17 years. So I was happy that it was still a relevant question. So 4-RIF had better completion in adults and children. It's safer in adults by a considerable margin, and it's very well tolerated in children. It's non-inferior to 9-INH for TB prevention in adults and children. So a very kind of cartoonish schematic. So we have, in terms of effectiveness, we have three regimens that seem to be very similar: 9-INH, 3-HP, and 4-RIF. In terms of safety, we have really only 4-RIF is significantly safer than 9-INH. The other regimens are at best the same. So recommendations. So I would say, and these are personal recommendations, not official, of course. First, definitely 4-RIF should replace 9-INH. I think you can choose 4-RIF or 3-HP, but really it's time to get away from 9-INH. At least in high-income countries where active TB can be excluded. Again, you don't want to treat active TB with RIF alone. But in Canada, I don't think that's an issue. We get good quality x-rays, we can get access to sputum cultures, etc. I think 4-RIF is good for most people who you judge reasonably likely to take therapy, knowing that's always difficult to predict. It's unclear in terms of an age cutoff. Adverse events, I didn't show you this, are not really age dependent with 4-RIF, so we're not 100% clear how safe it is in the elderly, but to date, we would say it seems to be. I'd say the main drawback of 4-RIF are drug interactions. Hormonal contraception of any kind, very important in young women. HIV meds, transplant meds, the new oral anticoagulants, those all have important, very important interactions, and you need to consider those. And that actually is probably the reason why you still have to think about 9-INH for some patients. 3-HP is a good alternative. Remember that rifapentine has the same drug interactions as rifampin, so you're no better off there. Although it's not that much different in terms of duration. So in terms of managing drug interactions, you still have 4 months, 4.5 months to manage. I think 3-HP is a good alternative for selected populations where adherence or completion historically has been a problem. But I think I would caution anyone considering it to make sure there is adequate medical backup and supportive therapy, aka resuscitation therapy, available. So in cities, in small cities with hospitals, sure, but I think in rural areas or especially in remote areas, I would be very cautious using this regimen. And I think that's it. I'm going to stop. I'm going to just show the acknowledgements just because there's many, many, many people to acknowledge for these series of studies, both for funding for CIHR, Australian MRC, the Brazilian funding agency as well, my own salary support for some of this, and needless to say, numerous people who assisted, the patients who took part, and all kinds of people here who've helped. Thank you, and I'll turn it back to Elizabeth.
Okay, thanks very much, Dick. So everybody listening, this is your chance to start typing away in the question box, which you should see on the right-hand side of the screen. So while people are typing, I'm going to start off with a question that may be more specific to where I work in Toronto than some other places. About or up to 15% of people who have active TB in Toronto have an INH resistant strain. So presumably it's the same proportion of people with LTBI actually have an INH resistant strain. So on the one hand, that makes rifampin really attractive because presumably right now, a bunch of the 9 months INH that we're giving is ineffective in the first place. But right. It does raise a lot of concerns about the possibility of creating an MDR strain if we miss somebody with early active TB. So could you just talk a little bit about that issue?
Sure. So first of all, we have a lot of information on acquired drug resistance in people taking INH, because of course it's been around for a long time. There is no evidence in randomized trials that INH, taking monotherapy with INH, causes drug resistance in people who've been reasonably screened for active TB. Now, reasonably screened, if you look at those randomized trials, usually is a chest x-ray, almost always, and may include sputum examinations and so on. Does not, none of these randomized trials did CT scans or anything like that. So a chest x-ray and a symptom screen is adequate. The problem in low and middle income countries is that they don't have very good quality chest x-rays. And so you can miss, active disease. But there is quite a margin of safety. I mean, you don't need to worry. You get a decent quality x-ray and someone's feeling fine. I think you can just go ahead. The risk of developing MDR is very low and is actually much higher if you don't treat them and you just let them develop disease. There's an appreciable risk that they'll develop MDR if they start with INH resistance during active TB treatment. So not only do you prevent TB, but I think overall you actually prevent MDR by giving rifampin early. That would be my take. So you need to do a chest x-ray, symptom screen, but that's all.
Okay.
I see there is a question I see on my screen.
Mm-hmm.
So should I just read it and go on, or go ahead?
Sure. I'll say the questions. How about that? And then it's...
Sure.
Okay. So first question, can you discuss the rationale for INH in the 3HP regimen?
So that's a good question. I'm not convinced that it has any role at all, because the INH does not have the long half-life. And in fact, it may only be adding, pill burden and toxicity. But in the mouse studies, it was given combined. So I think, and in the human studies so far, it's been given combined. So it's difficult to say, oh, let's just get rid of it. But yeah, the rationale came from the mouse study, and why they thought they needed it, I don't know. But in the mouse studies, it was used and was shown to be effective, and so on.
Okay. I'm going to read out another question. First, congratulations on 2 amazing game-changing studies in adults and children. In your presentation, you talked about individual risk versus public health benefit. Let me turn that around and talk about individual benefit versus public health risk. Even among clinicians in hospital settings that have access to sputum induction and who may be extremely diligent in ruling out active TB, from time to time, some patients who are thought to have latent TB actually have what's called active TB. Treating with rifampin. So this is the same concern about what if we
Sure.
fail to adequately rule out active disease. My concern is that widespread use of rifampin in community settings or resource-limited environments where sputum induction is not readily available and where the ability to definitively rule out active TB may be suboptimal, may lead to an increase in rifampin resistance.
Sure.
Accentuated in patients with fibronodular disease, that kind of thing.
Okay. So first of all, thank you for the comments at the start. It's a very important question. How hard do you need to work to rule out active TB? So again, the evidence that we have is all from INH. The randomized trials, no trial was doing sputum induction. They were doing regular sputum. They were doing regular x-rays. There is a very interesting study which was published in the New England Journal back in the 1960s. It was actually the first US public health study of INH treatment. They took child contacts, household contacts, and about, I can't remember the exact numbers, but about 20% of those children had hilar lymph nodes, and about a little under 10% had infiltrates in their lungs, judged by an independent panel of experts and so on. So most of us would now say, oh, those kids had disease, but they were all enrolled on INH, and remarkably, they all did fine. So from the earlier randomized trials where they took certain steps to rule out active TB, which were, not even as much as you're describing, and from this very first US public health study, there's quite a margin of safety here. Okay? I mean, of course, I'm not advocating that if you see an infiltrate on chest x-ray, you should give the INH or RIF alone, but I don't think we need to worry quite as much about, a tiny streak in the upper corner of the X-ray and have everybody doing three sputum inductions, etc. And especially because rifampin, actually, the likelihood of developing resistance is orders of magnitude less based on the spontaneous mutation rate. So you should need, at minimum, clear infiltrates, if not a cavity, before you're going to get into trouble with monorifampin. So that's a long answer, but it's an important question.
Okay, thanks. Here's another question. Can a breastfeeding mother be given rifampin safely?
Yes. So a breastfeeding mother can take rifampin. It is excreted in the breast milk. There is a publication, which again, I don't have the reference off the top of my head, but they estimated around 3 to 5% of the various first-line TB drugs of the total dose is excreted in the breast milk. So in a very young child, you actually have to adjust the doses if you're treating the child as well. So that requires a bit of consultation, but it's not even an adequate dose for a newborn. So they do get some exposure. So if you're thinking of treating the child, you have to perhaps consult with somebody to get the right dosing adjustment, but it's safe.
Okay, thanks. Here's another one. Isoniazid can be given intermittently by DOT for certain patients. Is it possible to give rifampin for LTBI intermittently?
Well, of course, theoretically it's possible. I have to say there's no good data. There was a study done in Saskatchewan where they used, I think, twice weekly, but I'm pretty sure they used INH and RIF together for 6 months, and they had very good results. But at the moment, there isn't any study that I'm aware of that has looked at intermittent monorifampin therapy.
Okay.
So, you can try it, but you're sort of skating in an evidence-free zone.
Okay. Given the interactions with hormonal contraception, is there any reason why 4 months rifampin might not be given immediately following childbirth, but before the pregnancy-induced hormone changes return to baseline?
Okay, I'm not quite sure I understand that question. I think that I would certainly start rifampin, within 2 weeks of after childbirth, assuming you've waited till childbirth to start it. I don't think there should be much difficulty there. The only thing is, you have to still caution the woman to take measures not to fall pregnant again.
Right.
You can't rely. I guess you might think there's a bit less natural protection, but that natural protection isn't exactly that reliable anyway. So.
Okay. From a practical perspective, should we in public health encourage this regimen with our family doctors or limit it to people who can access specialist care, such as ID or respirologists?
Sorry, this is for RIF or 3HP?
For RIF.
No, I think I would encourage everybody to use it. It's safer than 9-INH, and right now, at least in Quebec, 9-INH is prescribed by family doctors and all manner of different specialists. So I certainly think it's a much better alternative, much safer than that. So I would definitely encourage use by private providers. With the same, rule out active TB, be careful of interactions. Those kinds of things.
Right, and if it's a bad chest X-ray, then refer on before you give.
Oh, yes.
That kind of idea. Yeah. Okay. Did you look at or find any difference in rifampin adherence in children taking liquid medication versus pills?
Okay, so we didn't explicitly look at that. In the low and middle income sites, we actually have tablets of rifampin, so they were crushed, very much like the INH. So we use the same protocol of preparation for the two arms. in in Canada where liquid was available, I think often kids were getting liquid, but I've not analyzed that.
Okay. I just want to note we're past 1 o'clock now, so I'm going to read out one more question, and then we should probably close down. There's clearly a lot of interest. So last question I'm going to read out. Do you think there's enough post-marketing surveillance now for 3HP to lessen concerns regarding anaphylaxis or severe hypersensitivity reaction?
No.
Okay.
No, I mean, this was a well-done randomized trial. Why would it go away? People have not understood it. It may be, twice weekly may be better, maybe the highly intermittent nation, but it's really not understood. In a carefully done, carefully monitored randomized trial, you saw, there was clearly an excess of events, severe hospitalization and so on. It's rare. That's why people, you can give it to 50 people and you won't see it. Great. You're like, oh, I'm okay here. Mm-hmm. But it's, it's out there. And if you use it enough, you're going to see it. And if you're not ready, you're going to have a disaster on your hands. So I would be just prepared for it. I think it's a great regimen. It's very efficacious. It's very simple to administer, obviously. It's ideal for certain populations, but you really need to make sure you're organized to follow people and support them if something happens.
Okay. There are a bunch of other questions. So if you're okay, we'll send them on to you. And if you're able to answer any of them, then we can circulate that back to people who signed on for the webinar.
Sure. Yeah, no problem. So I take you'll send me sort of a batch of questions, and then I'll answer them in batch back to you, and then you'll circulate them.
Yeah. Sure. That sounds perfect. Yeah. Thank you so much. Okay. So thank you very much, Dick. It's a fabulous study, and thank you very much for talking about it today. I have a couple of save the date announcements. There is another Stop TB Canada webinar coming up on March 20th at noon for World TB Day. The Stop TB Alliance and FIND are going to be talking about global priorities for research and development in TB. So look for that webinar invite. And also the Union North American Region TB Conference is coming up in Vancouver, February 21st. You can find the information about that conference on the BC Lung Association website. So thank you, everybody who called into the webinar, and thank you again very much to Dick.
Okay, thanks all. Pleasure. Okay.
Bye, everybody.
Bye.
Thank you.
Thank you.
Thank you, Elizabeth. Thanks, Dick.
Thank you. Thanks for all the help.
Yeah. So I'll gather the rest of the questions and I'll send it to him by email, and then I can circulate the answers with the
that's perfect. Okay. Thanks very much. Bye.
All right, Elizabeth.
Yeah?
Thanks a lot. We'll talk to you. Bye.
Bye.